Hello everyone. Welcome to another webinar from the AMA Steps Forward Innovation Academy. Today we'll be discussing advocacy and support for medical student, resident, and physician health and well-being. Over the next 45 minutes, we will highlight the latest trends on issues facing the physician workforce and offer organizational changes that can improve the work environment for physicians and the care team. We will also discuss the crucial role of credentialing reform in supporting physician wellness, advocating for confidentiality, reducing stigma, and fostering a culture of support. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. On the webinar today with us is Michael Tutty, GVP of Professional Satisfaction and Practice Sustainability here at the American Medical Association, and Daniel Blaney-Koen, JD, Senior Attorney with the American Medical Association Advocacy Resource Center. The ARC attorneys focus on working with state and specialty media societies on state legislative, regulatory, and policy advocacy. And with that, Michael, take it away.
Thank you, Alec, and I appreciate everyone being here today. Daniel and I are going to try to get through our presentation. We've got a lot to cover in about 30 minutes or so. We'll leave some time for questions at the end, and we'll promptly wrap up at quarter of the hour. So thanks again for being here. What are the issues that the AMA is trying to work on to assist physicians, residents, and medical students when it comes to addressing the burdens that they face? As you know, out there in your roles, physicians, residents, medical students face a ton of burdens. On this slide here, you can just see some of the burdens physicians face day to day in their practice. That work volume and the control over their work, the reimbursement and reporting issues, the ongoing regulations and risks, and other things like negative online reviews, more patient messages coming from patient portals. All of this building up day to day makes it harder and harder for physicians to provide high quality patient care for their patients. And that's the thing that we've been trying to work on for the last decade, is try to remove the obstacles, remove the barriers that make it harder to practice medicine than it should, so that physicians and medical students and residents on their journey to become physicians can do what they need to do most, which is caring for patients. So we want to talk about how you can support the physician profession and medical school and residents to maintain, return joy, meaning, and purpose. So it all really boils down to the quadruple aim, and sometimes we hear about the quintuple aim, but the quadruple aim, published in 2014, was the first time we added this clinician wellness to the triple aim of better outcomes, lower costs, and improved patient experience. This fourth aim, and now with the fifth aim of health equity, is really about the importance of caring for those who care for others, knowing that we cannot have better outcomes, we cannot lower costs, we cannot improve the patient experience without clinician well-being, without the well-being of the care team and those who are caring for our patients. And what we've been talking about a lot, and has really kind of talked about more in the last number of years than when I started this work in 2013, 2014, was this term burnout. And at the AMA, when we talk about burnout, we're really talking about a workplace phenomenon. And that's how we think about burnout. Something that happens in the workplace. Something that, while it happens to the individual, we know that it's the workplace that is causing this burnout for the individual. And it's characterized by three things: that emotional exhaustion, I can't take it anymore, I don't want to go to work today, I'm just tired, I don't want to do this. Decreased personal achievement, what's the point, of doing this work? I'm not getting this personal reward anymore. Maybe I feel like I'm spending more time in front of a computer than spending time actually caring for patients. And this depersonalization, this kind of cynical and negative attitudes you might hear from individuals about their work, about their colleagues, and worse, about patients. You may hear a burned out clinician saying that train wreck in exam room 1. It's these feelings about the work that one has experienced, based on all of these burdens that make it harder to practice medicine. And so at the AMA, we've been tracking burnout every 3 years since 2011, a national burnout study. And you can see we peaked in 2014 and had this downward trend in 17 and even 2020, which is a little bit shocking if you recall what was happening in 2020, a little thing called COVID. But when we were in the field in the fall of 2020, we were at a point nationally where I think we had gotten away from that first urgent sort of spring, summer panic and concern about COVID. And there was this positive feeling as a nation that we were coming together, clinicians were working together, physicians working together to care for the patient population. And as a matter of fact, depending on where you were in the country, as the COVID pandemic did not roll out equally across the nation, and if you're a specialty where you do a lot of preventative services that might have been getting postponed, you've actually might have seen some decreased workloads and this personal sense of accomplishment that we're fighting this thing together. And you remember a lot of the positive signage in front of hospitals and medical centers. We care and love our physicians and nurses. But instead of waiting until 2023, as we usually do for our 3-year study, we decided to go back in the field in 2021 because what we were hearing was different. And you can see that in 2021, burnout became an all-time high, characterized by this sort of long-term fatigue of dealing with all the changes, all the additional burdens that COVID have happened. And I would argue some of the increased politicalization of healthcare, and all the things that were going on. We've did our study in 2023. The results have been accepted for publication. It should be out any day now. And we're back in the range of about 2017 numbers in 2023. So back down, but still higher than it should be nationally. And importantly, higher than it is compared to other professions where particularly burnout is lower in those who have more formal training. So what are we seeing in healthcare more generally? If you look at medical student applicants, interestingly, after COVID, where we had a little bit of a dip, we saw the highest number of applicants in the 2021-2022 application year. Some of that was a little bit of a pent-up demand from COVID, a lot of interest, and we've seen a slight decrease the last 3 years of medical school applicants, although the number of accepted into medical school, you can see, continues to grow. So we're growing the number of medical students, and we're also seeing similar things in osteopathic schools, increasing the number of students, which is very positive for the profession. We've been increasing the number of residency slots in the profession. You can see we've had the 2024, we had the most training positions available, although you could argue clearly we need more residency slots. So we're training more in medical school, we're increasing the number of residents, but the AAMC is projecting a shortage of physicians. So we're training more on one hand, medical students and residents, but we're projecting a shortage. And the latest last year that came out from the AAMC talked about this shortage being driven by population growth as our country, we get more people in the country, and an aging of the population. As the older you get, you need more care. A huge number of baby boomer physicians entering the retirement age. I read some number of a very large statistic in the next 7 years, how many physicians are going to be retiring. But one of the things that also concerns me is physicians leaving clinical care before retirement age. And we've been doing a lot of research to understand why physicians choose to stop doing clinical care and what we can do to try to keep people at least part-time doing clinical care, as we need as many physicians doing clinical care as we can. And what we're seeing in some of our research, and now this is self-reported data, so it's not actual people leaving or reducing their clinical time, it's self-reporting data, but research has backed up that there's a high correlation to people who say they're going to reduce their clinical time or leave reduce or leave doing clinical care. So 2 in 5 physicians intend to reduce their number of clinical hours in the next year, and 1 in 4 talk about leaving clinical practice altogether. And while reducing clinical time has actually been shown to address burnout for physicians who choose to spend less time doing clinical care and other time doing other activities, it does require, obvious, for us to train more physicians and have more physicians available to meet patient demands. And so that will be a challenge for us as a nation. So what we like to talk about, and what I mentioned before, is that will burnout manifests in the individuals, right? Burnout is an individual symptom. We believe that it's mostly driven by the system. And so at the AMA in the last decade, and Daniel will talk about some of the things we're specifically doing around things like credentialing and the like, we understand that it originates in the system. So we've been very focused on how we can help organizations improve the work environment, whether that be the practice, the hospital, or the health system, while we also try to regulate changes that are positive for the profession at the state and federal level. Now, there's a lot of individual solutions as well, things like coaching or well-being, mindfulness training and programs like that I've personally gone through and are very positive. But we have really focused on both the organizational opportunities for improvement and those opportunities we can do at a larger U.S. healthcare system at the state and federal level as an organization. And so we know when physician satisfaction is high, and physicians feel like they're able to deliver high quality patient care, we see increased patient satisfaction, increased vaccination rates, better outcomes, obviously higher retention and full-time effort for physicians, and improved trust and productivity. When physicians are burned out and we see more obstacles interfering with delivering patient care, we see patient mistrust go up. We see the numbers of physicians talking about leaving practice go up, the potential for more medical errors, more likely referrals in costs, and even obviously the worst outcome, things like physician suicide. So I want to start by talking about now how we can think about solving this problem as we kind of teed up a little bit of context. And I first want to talk about taking care of yourself. You know, it's the old adage you always hear about the airplane, put on your mask before helping others. And that's the same true as here. We're going to talk about some ideas and ways that you can advocate and get involved for improvements in your organization or at the state level by doing some larger advocacy. But it's got to start with taking care of yourself. And if you're feeling that burnout symptoms that we talked about, that depersonalization, that sort of emotional exhaustion, that sense of lack of personal accomplishment, maybe it's time for you to step back and think about ways that you can make sure you take care of yourself and then get involved in helping your organization provide opportunities for improvement for all the clinicians within your organization or your residency program or your medical school. And I would encourage you, and if there's one takeaway from my portion of the talk that I'd want you to take away, is be curious and not judgmental. If you ever watched Ted Lasso, one of my favorite episodes is where Ted is playing darts, and he does this great story about seeing this Walt Whitman quote that sort of reminded him why people used to pick on him when he was a kid, and that people were not curious and they were judgmental about him. Interestingly enough, when I went to go look this quote up I got from Ted Lasso, I don't know if Walt Whitman actually said that, which is why I put not Walt Whitman. But be curious and not judgmental. When you start to look around on why we do things in our practice, in our residency program, you start to do it from an inquisitive mind, you start to ask questions. When we've been doing something day in and day out, every day a certain way, sometimes it takes a fresh set of eyes or someone new to the organization. And it's like, why do we do that? Are there opportunities to do things different that can improve our environment? And so a study that came out in 2017 that really was an eye-opener for me was something that was done by Don Berwick and his colleagues at IHI, where they asked clinicians and patients and others, if you could break or change any rule in service of better care experience for patients or staff, what would it be? So if you could improve anything in the hospital, anything to provide better care, what would it be? And they collected 342 items. And when they started to sort them, what they say is, contrary to initial expectations, although wasteful statutory and regulatory barriers existed, the majority of obstructive and wasteful rules identified by patients and staff were fully within the administrative control of healthcare executives and managers to change. And that is so powerful. And while there are things that we need to fix at a regulatory level, at a national legislative level, and that is the work that we at the AMA are doing and our advocacy colleagues like Daniel are working on, there are so many things that we can change within our own organizations. And I think that gives hope. I think that gives optimism that more than 3/4 of the frustrations you may be feeling are actually things you can fix. while we're also working on some of those larger national regulatory and legislative fixes that we need to fix. And so one of the things we see is that we're so busy, we're so head down that we say no thanks to the opportunities for improvement. Hey, I just got to get through the day. I got a full patient load. I don't have time to take a step back and look at ways to do things differently. So we've got a whole bunch of content called Steps Forward, available at stepsforward.org, which are free complementary resources around ways to improve your practice. One of the favorite ones, a toolkit that we have, is getting rid of stupid stuff. And if stupid stuff is not a phrase you want to use in your workplace, you can call it GROW, getting rid of waste. And it's really about identifying opportunities that you can find within your own organization, maybe your residency program that we want to eliminate. And how you brainstorm those activities, and just go free brainstorming, having people suggesting ideas, writing them down on yellow stickies. What are the frustrations? And then going through and grouping them. Is it a simple logical issue that we can just fix? Let's just fix it. Is it something that needs a little bit more complex? We've got to put a work group together, might need some management decisions, it needs further investigation. And maybe there's some things that just aren't possible. Those are legislative fix. We have to do this because that's the way the Joint Commission requires us to do. But you'd be surprised at how many things you can move quickly and how many you can fix. And Daniel will tee up a few ideas in his part of the conversation around things around credentialing and opportunities that are some low-hanging fruit to improve well-being in your organization. I mean, it literally could be as simple as get a group to brainstorm some ideas and then kind of put them on a 2x2 graph. Get it high impact and easy would be the ones I'd prioritized. High impact and hard, and easy and low impact you might want to do. And those low impact, hard are ideas that we're not going to address. It's as literally simple as that by thinking about ideas for improvement. And again, we'll talk about a few in the second half of the presentation. But I wanted just to tee up this idea that you have more power in your role to be a voice of change, to look at things with an inquisitive lens and find opportunities for improvement. Because as that IHI study said, more than 3/4 of the rules that were identified that were burdensome were actually able to fix within that organization. So I'd encourage you, and I'll stay on this slide for a second here if you want to use the QR code, to go to Steps Forward, where we have lots of complementary resources. We have playbooks and toolkits around all sorts of ideas to improve. And one of my favorites is our Saving Time playbook, because who doesn't want to save time, with a whole bunch of suggestions to identify opportunities for improvement. And then we have a whole idea around looking at some of the overinterpretation and misinterpretation of restrictive policies that create additional burden and cognitive load and dysfunction for care teams, and have a toolkit specifically around reducing that regulatory burden. And so you might find something different depending on where you are, if you're in a residency program or not. And we have additional resources like our organizational biopsy, where we'll come in and survey physicians. If you're a health system, we also have a specific survey tool for residents. And then we also have things like the Joy in Medicine Health System Recognition Program, where you may want to encourage your employer, if they're not already, trying to strive to get a bronze, silver, or gold, where they're self-attesting to doing certain activities to improve their physician environment. And if you're early in your career and you're looking for an opportunity to get hired, you may want to consider, is your health system that you're considering, if you're considering between two, one that's a Joy in Medicine Health System recognized organization. And finally, before I pitch it over to Daniel, is regardless of these ideas that you come up with, the importance of making that pitch. You don't want to come across as someone who's very upset, because whoever you're making the pitch to, it could be your residency director, it could be your CMO, it could be the head of your practice. They're also stressed and busy. So understanding how to tailor your message to which decision maker, right? A finance decision maker may be more concerned about the finances. What about the other end users? What about the nurses who might have feeling like some changes might impact them? So understanding who the decision makers are and how to tailor your message makes it more powerful that you can be an agent of change in your organization. So let's talk a few more specifics, and I'll throw it over Daniel to talk about some of the opportunities.
Thanks, Michael. Yeah, I want to, in about the next 15 minutes or so, I want to go through, rip through some very tangible actions that everybody can take. It was kind of fun, perhaps one of the only fun things about virtual. I'd rather be in person with everybody. But virtually, you can see who's on the call, and it was great to see among the attendees a lot of people that we've worked with before. As Alex mentioned, I'm one of the lawyers at the AMA, and I work directly with a number of outside organizations to influence change at hospitals, health systems, medical boards, and other areas. And one of the lessons, I want to pick up something Michael said that was just super, super important. Every single person on this call has the opportunity to start change within your system. Whether your system is a medical board, a legislature, or a hospital or health system. Every single person, and we've had literally hundreds of examples of individuals starting that change. And I'm going to talk about a couple of the very specific targeted ways to do that. To sort of build, to build on what Michael was saying, these ideas about burnout and people who need care and who want to seek care, it affects every physician. Some specialties might have a slightly higher percentage, but it affects everybody. And but most people also don't seek care, and that's what we're trying to do, is to remove the barriers that cause people to not seek care. And I'm going to go through some of the very specific ones. I want to start out with, and I do this. This is really kind of a bummer slide. The rest of everything is going to be optimistic. But one of the tragedies of burnout and not seeking care is that there are people who are no longer with us, people who have died by suicide. That affects families. That affects us all. It affects colleagues. And these are individuals, it's all publicly available information. And we have to remember that behind this is part of the reason we want to do this. We don't want people to get hurt. We don't want people to, take their life, as a result of not seeking care. And we always bring it down to that very human level. Why are we doing this? Because we can help at the very individual level, and that's absolutely essential. So what are we trying to do here? Why do people not seek care? There are a lot of reasons, but some of them all sort of coalesce around people are scared of letting other people know. They're afraid they might think that if I seek care that I'm weak, or if I seek care, I'm putting my license in jeopardy, or I'm not going to be able to practice medicine anymore. And so what can we do to remove that stigma of doing that? We know, and again, I'm a lawyer, so I don't have all of the research at my fingertips, but I've read a considerable amount of it. Healthy physicians are safer physicians. And so we want to encourage physicians to be safer. We also know that trying to recruit a new physician who is not in practice for whatever reason, it's really expensive. So as Michael said, know your audience to make your case. And whether your case is to a hospital or health system, you want to support wellness because healthier physicians are practicing. They're earning you money. We want to make the case to licensing boards. Healthier physicians don't register complaints. They provide that safe, competent, ethical, professional care. These are the important things to consider when talking to your various audiences. And what we're trying to do, part of this campaign, this advocacy campaign, and that's what we do here at the AMA, is this advocacy campaign. We want to build consistent national use of non-stigmatizing language. Let's get right into it. This is AMA policy. So as many of you on the call know, I am guided by what AMA policy that is created by physicians across the country. Every state medical society, every national specialty society, more than 150 medical societies have come together twice a year to develop AMA policy. This is what we're basing it on. But the language that we've worked with many of you on the call on to revise your credentialing applications, to revise your peer review forms, to revise medical licensing applications, and other forms is based on the policy that has been developed by the AMA House of Delegates. It's not what Daniel Blaney-Koen thinks is a good idea. It's not what Michael Tutty thinks is a good idea. This is what the physicians of America, after debating and coming together and coming to this consensus. But it doesn't mean that you have to change your applications to have this exact language. We want consistency. Let's go into that a little bit more. We started doing this in about 2021. 2022, this national campaign. This is where we were, about 20 to 23 states. Medical boards had this type of application, had that consistent language. About 75 or so health systems had that consistent language. Move forward at the end of 2023, beginning of 24, we worked about 25, 26 states, a couple of hundred health hospitals and health systems. And just recently, with our partners at the Dr. Lorna Breen Heroes Foundation, you can see the numbers here. This campaign is just exploding in terms of people recognizing that this language is really important. The language that I showed to you previously, it focuses on ensuring that the only type of disclosures that need to be made are whether somebody has a current impairment. If you need to seek treatment, you can go ahead and seek treatment without the fear of having to disclose that treatment, unless there's a current impairment. That's the balance we're always trying to seek. Hospitals and health systems need to know if there is a current impairment or if there is a reasonable accommodation that's needed. Hospitals and health systems need to be able to balance the risk. Licensing boards need to be able to balance that risk of patient safety against encouraging treatment. We do not support questions that require disclosure of past treatment or diagnosis of a mental illness or substance use disorder. We do support disclosure of current and treatment, and that's the balance. And we're now at a point where, and we just released this I should say the Dr. Lorna Breen Heroes Foundation released this just 2 weeks ago. It might have even only been last week. And we're already out of date because we've already had, I think, 3 or 4 additional medical boards that have changed, that we've verified they've changed their questions. And we've already had, I think, 6 or 7 health systems that have changed their questions based on our recommendations. And again, they're not necessarily exactly the same language. We're not the grammar police, but we do want the same consistent, no past diagnosis, focus on current impairment. That's the balance we're trying to seek. So what are exactly the language that we're trying to look at? Here's some things that we do not support. It's an example, and all of these examples, come from actual work that we've done, actual technical assistance that we've provided. Technical assistance, fancy term for we read the applications. This is a focus on past treatment. Again, remember the data says, if you ask about past treatment, I'm scared about seeking treatment. So we're trying to remove that barrier. Do you have a physical, mental, or we see a lot of this variation of this kind of this kind of question. Now, keep in mind, if I have high blood pressure, I might have a stroke. If I have heart disease, I might have a heart attack. If I suffer from headaches or migraine, I might have blurry vision at some point. And for the physicians or the healthcare professionals on the call, if I get the medical terminology wrong, I apologize. Again, I'm a lawyer. I just work for doctors. But the point is, one of the common elements of chronic disease is there might be a recurrence of symptoms. So we don't want to say whether something might occur. We want to focus on whether there is a current impairment. Similarly, and these are other examples, as you can go through and read them. These are actual examples. And all these examples I'm showing you are examples that we've ultimately wound up working with the health system or the licensing board to change. This is, the screen's a little bit small. Like, let me put on my old man glasses here. It's much better. So you can see, so some of these kinds of questions also get at medication. If taking medication improves a condition, whether physical, mental, or behavioral health, if it improves a condition so there is no current impairment, we want to encourage that. We want to encourage somebody who's following the treatment regimen to follow those therapeutic recommendations, of their physician, so that a chronic condition or a treatable condition supports the ability to provide safe, competent medical care. That's what we're trying to do. We do not support this kind of question that equates the taking of medication as a negative consequence of something. We want physicians and all healthcare professionals to feel comfortable in their treatment, that they don't have to disclose these types of situations. Before and after changes. So here you can just see, before, focus on the past. Change, focus on the current. Again, before, focus on the past. after, focus on the current. This is simple. This language is sort of simple, but as those of you who have gone through these efforts, whether it's through the work that we're doing with the Breen Foundation or the work that you're doing to get recognition through the Joy in Medicine program, the work is not necessarily difficult, but it takes time. And sometimes you have tough questions. One of the promises I'll make to everybody on the call, and you've heard me say this before, if you have questions about your own applications in your own system or your own state, just send them to me and we'll talk through it. And then we'll provide you with formal recommendations on what things look like. And we've done that, as you saw in the previous slide, we've done that for hundreds of systems and states already. And we'll do that for every single person on the call who's willing to do that work. Again, before and after, we'll send, Alex will make these slides available to people before and after. Sometimes some people have said, you know what, we don't really need to even ask any questions about medical, physical, or behavioral health conditions. There is one other aspect that we always encourage on these applications. Take a look at your own applications in your system or for your state. Are there positive statements about how you view individuals seeking treatment? Are you encouraging people to use your state physician health program, for example? That's a powerful statement that you can make as a hospital, health system, or state, saying that you encourage individuals to seek treatment. And if you get into the details of reading this, you'll see there's always the balance. Individuals have an obligation, applicants have an obligation to notify the system or the state if there is a current impairment. But also the state, we believe, has an opportunity to support people to receive treatment before a treatable condition becomes an acute condition. And certainly no one wants an adverse patient event, if there is something that could have been treated ahead of time. Again, before and after. And again, Alex will make these available, and I'm belaboring this a little bit just to demonstrate that you can make these changes, and many people have made these changes. Want to point out that when we talk, this is just an effort that took place in Massachusetts, where everyone came together to change the statewide credentialing application. It's not often you see all of these partners, on the same page about healthcare issues. This is one where we think it can get done. This is the type of effort that's also taking place in North Carolina. It's starting in Michigan, in New Jersey. If you want to be the leader to get everybody, all the players in your state together to take this kind of statewide effort underway, let me know. Send me an email, and we'll go ahead and start taking those steps together. Legislative options. Michael mentioned legislation a bunch of times, and I want to make a couple of points. One, I have no problem supporting and getting involved in state legislative efforts. Legislation can be complicated. States don't have to go the legislative route. Sometimes it can be a little bit tricky, getting in the legislative route. More than happy to do it, not necessary, but we are doing it, and we're involved in efforts in Arizona and Colorado this year already, and we've supported laws in about 10 other states already. And I'll mention two of them. The first, Virginia, and I'll mention two of the best. Virginia requires regulatory boards to ask these two questions. These are great questions. You'll note that these are not exactly what the AMA language is, but it is consistent, and we strongly support it. And huge shout out to the hospitals and health systems in Virginia, and the Medical Society of Virginia, and the Virginia Healthcare Hospital and Healthcare Association for their leadership on these issues. Because I think it's about 75 to 80% of Virginia's hospitals have adopted the recommendations that we have, and that's just fantastic. Second, Minnesota. And this is more focused on hospitals and health systems, going on the credentialing side of things. And this just went into effect in January, and we're looking into how well the hospitals and health systems are complying. Have they made all the changes? And we're going to audit. We're going to hopefully work with everyone to audit to make sure that has actually taken place. Debunking the myths, real quick. There are a lot of myths, and here are just some of them. And that's a little bit too small, so I'm going to look at my cheat sheet that I have in front of here. But I want to highlight one thing, and I'm not going to go into each of all of these because we want to try to get to some questions. But we get a lot of questions about, well, so-and-so said we can't do this. And we get questions said, well, if we do this, aren't we really hurting us or hurting ourselves, our ability to police our employees, our medical staff. And I'd say each and every myth we've encountered, the last almost 5 years now, 4 to 5 years of doing this, each and every myth we've encountered, we've wind up debunking. Sometimes these myths have taken a couple of years to get to the bottom of. For example, one myth was the Joint Commission requires us to ask questions about past diagnosis of mental illness or substance use disorders. And it took us over a year to get to the right people at the Joint Commission. And they were like, no, we don't. And we're like, well, can you publish that? And they said, absolutely, we can publish that. They're a phenomenal partner in doing this. NCQA, a lot of you are familiar with NCQA. A lot of people said, NCQA says we have to ask about past drug use. We finally got to NCQA and said, do you guys require knowledge about past drug use? And they said, no, we don't. So they published something in one of their FAQs. We don't require that about past drug use. And there are a number of other myths that we've heard. We've heard them all. Sometimes we get new surprises. We're always willing to track it down. My point is, if you think something is preventing you from making these changes, please let me know. Chances are it's not the case. Finally, resources, link there. Alex will provide you the information. And that is who Michael and I are. Alex, I'll turn it back over to you for Q&A.
Awesome. Michael, I know you have some teed up, right?
Yeah, we got a whole bunch of questions, Daniel, for people who registered. Let me throw one out to you, and then I'll answer one second. But how can medical students advocate for themselves and well-being amidst high stress and high expectations for board prep and rotations?
Yeah, that's such a great question. The burnout and the fear and the stigma that we talked about, it's even a little bit higher for medical students and residents. I think there are a couple of things that medical students and residents can do. First, please reach out to us. Let us know what the specifics are. We're not going to share them with your program. We talk with medical students and residents on a regular basis. One of the other things is we can help you through how to go about talking to your program about this. There's a medical student at a large institution in the Northeast in New York who is concerned about this and reached out to a physician at the Dr. Leonard Breen Heroes Foundation and said, how do I do this? And we worked with that student to go to their program director and say, we want to change these questions. And the program director did it. And they changed those questions. The same thing happened in Minnesota. So the Minnesota law is really the second thing that Minnesota has done, but the Minnesota Board of Medical Licensure changed its questions because a group of medical students went to them and said, we need to make changes. And the board said, we don't hear from medical students that often. Come and talk to us, come sit down, tell us what you need. And that led to a series of events where the changes were made. Use your voice. Come talk to us, we'll help you.
There's a question that I'll take a stab at that talked about what has the AMA done well around well-being and where have we fallen short as an organization. So for the last 10 years, I think that what the AMA has done really well is in, putting our best foot forward and focusing on this issue and really understanding it and investing in the research. Way back in our seminal study back in 2016, that's still quoted, for every hour physicians spend with patients, they spend nearly 2 additional hours doing EHR and administrative work, which we did that study using medical students following physicians and tracking them on an app, to now where you can pull the EHR audit log down and know exactly how much time people are spending doing pajama time and the like, to a study that was just published in the news today in JAMA that we funded that talked about the increase in inbox volume, the number of patient messages increasing through the patient portal, and that additional burden. I think we've done a good job to study the issue. The challenge for us and for people like Daniel and I is we get a lot of issues that are brought to us. And the first question I always ask is, do we understand the issue? And if we don't, maybe we need to invest in some research. So if a physician says, I spend too much time after hours on the electronic health record, well, that's a complex problem. And so we spend a lot of time understanding what are physicians actually doing, what's arriving in the inbox and whatnot, and how can we kind of pull that apart and start to decrease that time. The second thing is if we understand the problem, is there a clear solution? Is there a solution that we know? And then the third question, which is sometimes hard to answer, is the AMA the right best organization to be the lead in trying to fix that problem? Because there are so many. And so we've learned which levers that we think the AMA can pull are of a piece of the problem. And that maybe, we try to bully pulpit sometimes, and maybe we've got to do more legislative solutions. Prior auth's a big one, where we work closely with the health plans and our health plan associations with not a lot of success. And now we're seeing more legislative wins on prior authorization. But we don't have all the answers, as Daniel teed up. And so we're happy if anyone wants to reach out with ideas or suggestions of things the AMA should be doing. We get the best information from all of you on what we should be working on. Daniel, why don't we each take one or two more so we can wrap up? What are ways to advocate for changes in laws to improve prior authorization burden in clinicians?
Yeah, right before I answer that, I want to go back to the previous question, Michael, because I want to emphasize something that you made, that you said earlier, which is the AMA might not have all the answers, but we develop resources based on practical solutions to directly help physicians. We don't do hypothetical stuff. That's not our business. Physicians don't treat hypothetical patients. We don't provide hypothetical solutions. So all of the STEPS modules, check them out. You really should check them out because they all might not be for you, but I'll bet there are a couple there that will really help you. The organizational biopsy, it might tell you something you already knew, but that just validates the work that you're already doing. So what we're talking about here is practical things for you to actually employ, in your practice for your system today. That's something really want to highlight, that you can do that. And if we don't know the answer, we're going to figure out where you can get the answer. We might not be the right person, but we're going to be able to help you get to the right person. So prior authorization, it is one of many barriers that physicians have. And in our advocacy unit, both on the federal and state levels, we are fighting directly against health plans. We know it's an enormous barrier that physicians have to hire 2 to 3 full-time employees to do something. That it's ridiculous that a health plan would go ahead and try to submit or supplant a physician's recommendations for its own financially driven reasons. So if you're having prior authorization burdens, one of my colleagues is supporting state laws in dozens of states on a regular basis to reduce that burden.
Awesome. I want to hit a couple things real quick before I turn over to Alec to wrap us up. A lot of questions we had on unionization. It's a hot topic of late. The AMA generally supports unionizations. We do have AMA policy that links back to the Code of Medical Ethics, though, that does say that disrupting patient care, i.e. striking, is not something that is wanted, that increased patient care. Interesting debate on that, and more interest as we've seen the growing number of unionization. The AMA was involved in unionization before my time, maybe before Daniel's time, and there was that time not as much interest, but lots of interest. And we've just recently completed some research around physicians' thoughts about unionization. I hope it'll get published later this year. Another topic, physician coaching. Very for physician coaching, and there's some programs mentioned, particularly people who want to make change and are trying to get that. We have a program called Mentoring for Impact, and we've coached some people who came back from a conference all energized, went back to their health system and kind of demoralized because they didn't have a clinical leadership role, and kind of coach them how to make changes within their day-to-day practice, document that, share it with colleagues, and watched people kind of rise up in their own organizations, taking more leadership roles, which has been very exciting. So thank you, everyone. Again, Daniel and I are always happy to help. We don't have all the answers. We appreciate your feedback. And I want to say thank you for everything you do day to day to care for patients. You are the people that Daniel and I and our colleagues work to help. So thank you, thank you, thank you.